Okay, welcome back, guys. Continuing along with part 2 of our dermatology high-yield practice questions. We'll pick up where we left off. So we've just finished with molluscum contagiosum. And now we'll move to this one. So you can see the picture here. What is this condition? What is the most common cause? And what is the treatment for this? What is the condition, most common cause, and treatment for this? So this is, of course, the common wart. The viral is the most common, HPV, type 6 and 11. Important to know. And remember, the types that can cause cancer are 16 and 18, as well as 31 and 33. But this is the wart, which is 6 and 11. It's thrombosed capillaries that are pathognomonic. So if you hear thrombosed capillaries, that's pathognomonic for this. Treatment is none if it's not bothersome, since most resolve. It is a viral infection. It resolves in about 2 years, but you could do salicylic acid, you could do podophyllin, you could do cryotherapy, you could do electrocautery. So there's multiple ways to actually take these off if they're really bothering the patient or they're immunocompromised or something like that. Next one is just a question. What is a soft, fleshy, cauliflower-like lesion ranging from skin-colored to pink and occurring in clusters from HPV, most commonly found in the genital region? What is this called? So again, cauliflower-like lesion. That's the big term right there. That's going to be condyloma acuminata. Condyloma acuminata. So don't get it confused with condylomata lata, which is in secondary syphilis. This is condyloma acuminata, an accumulation of many little condylomas. And again, cauliflower-like lesion. And remember, if we have HPV on the cervix, we can whiten it with acetic acid, and it shows up. So we can also do acetic acid whitening to make sure this is the correct diagnosis as well here. And we protect with Gardasil 9, of course. Next question, what is this? So you can see this picture here. What is this condition? Who typically gets this condition? Does this condition have malignant potential? And what is the classic description of this condition? So again, who gets it? Malignant potential and classic description. What is this? So this is SK's, seborrheic keratosis, and most common benign epidermal skin tumor. It happens in fairly older, fair-skinned people with sun exposure especially. Classically, how they'll describe it is a velvety, warty lesion with a greasy or stuck-on appearance. So I've seen that so many times, stuck-on appearance. And it has no pre-malignant potential. No pre-malignant potential for this. Again, velvety wart with a stuck-on or greasy appearance. And that's seborrheic keratosis. And how about this one? What is this? What can you see here? Lesions here, 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 and here. What is this? What can this progress to specifically? What exactly can this progress to? What is the classic description of this lesion? How do we treat it locally? How do we treat multiple locations that are numerous? Multiple locations, so maybe this patient, if they had even more. What weird thing can become of this? So what if we just have one? What can that actually progress to if it keeps growing? So that's going to be actinic keratosis. So different than seborrheic keratosis, which is benign, actinic keratosis does have premalignant potential in that it can evolve to squamous cell carcinoma. So importantly to know, AK can go to squamous cell carcinoma. Dry, rough macules or papules with a sandpaper texture, often with transparent yellow scaling will be the description. So again, sandpaper texture, important to know. If it's local, you can do liquid nitrogen cryotherapy just to ablate it basically off. But if they have multiple and they're all over their body, you can do 5-fluorouracil, which basically lights up all those lesions red, and you can actually see where the abnormalities of the growth are. So if they have multiple, 5-fluorouracil. What weird thing can become of this? It could actually be a cutaneous horn. So it actually literally looks like a horn, and that's for actinic keratosis can just evolve to a cutaneous horn if it keeps on building up in that one area. And again, they could describe it as hyperkeratotic plaques. And the patho is basically atypical epidermal keratinocytes. Atypical epidermal keratinocytes that are sandpaper in texture. Okay, next one. What is this? What is this? What is Bowen's disease? How common is this exactly? What is the classic description of this condition? And this condition is often preceded by what? So this is preceded by what? How do we describe this? How common is it? And what is Bowen's disease? So this is squamous cell carcinoma. And Bowen's disease is squamous cell carcinoma in situ. It has not invaded the dermis yet, so it's still in situ here. Second most common skin cancer overall, remember basal is the most common, then squamous, then malignant melanoma. So second most common skin cancer overall is squamous cell carcinoma. Sun is a risk factor. Actinic keratosis can precede it, and it's a risk factor. And HPV is as well a risk factor. How it will be described is erythematous, elevated, thickened nodule with adherent white or scaly crust or bloody margins as well. So again, scaly crust, white, adherent, thickened nodule. So it kind of looks like an actinic keratosis, but a little bit more evolved. And again, if it's in situ still, Bowen's disease. May present as a non-healing ulcer, and again, preceded by actinic keratosis, and don't forget, seborrheic keratosis is a benign condition. Okay, next one. What can you see here? What are these images of? What is the cause of this? What is the actual cause of this, and how do we manage this? And also, who's at risk for this? Who is at risk for this? Important to know. So what is this condition here? You can see it in the mouth. You can see it everywhere. So this is Kaposi sarcoma. So Kaposi sarcoma is human herpes virus 8, HHV8 is the cause. It's most common in immunocompromised patients, especially HIV with a CD4 count under 100, Kaposi sarcoma. It's macular nodular plaques that are brown and purple lesions, and they can also be described as violaceous as well. How do we manage this? We want to manage the underlying condition, so especially antiretroviral treatment if they're HIV positive, we want to do. Okay, what is this one? What is this condition here? What are the 5 things we want to look for when considering, is this what we think it is? What is the most common type of this or subtype of this thing? What is the most common? Where is it most common in men? Where is it most common in women? And how do we diagnose it specifically? What kind of test do we want to get to actually diagnose this thing? So this is, of course, malignant melanoma. We want to see the A, B, C, D, E. So asymmetry, is it asymmetric or is it circular? Does it have a border? Does it have color changes? Is it a large in diameter, typically over 6? Is it evolving as well? So evolving, diameter, color, border, and asymmetry. These are the factors that we want to look for when trying to figure out if it is malignant melanoma. Superficial spreading is the most common. And men, it's going to be most common on the trunk, and women on the legs. So again, that's an important one. Men is most common on the trunk, and women on the legs. How do we diagnose it? It's going to be a full thickness, wide excisional biopsy, not a shave biopsy. So we don't just want to get a scraping or a shave biopsy of this. We want to do full thickness, wide excisional biopsy. Okay, next one. You can see here in this image on the nail here and also on the nail here. What is this condition? This is acral lentiginous melanoma. So acral lentiginous melanoma. Hutchinson's sign is this classic sign that you see here with the black line, and this is also how Bob Marley died. So acral lentiginous melanoma. Okay, next one. What is this an image of? Multiple images here. How dangerous is this one specifically? What are the classic characteristics of this lesion? What is the most common location for this lesion? How do we diagnose it, and how do we treat it? So this is the classic one here in this bottom right-hand corner. So this is basal cell carcinoma. Most common skin cancer in the US. It is slow growing and locally invasive, but rarely leads to metastasis. So again, rarely leads to metastasis, but it is locally destructive. It'll be classically described as small, raised, translucent, pearly, or waxy, raised, rolled borders, importantly, rolled borders with central ulceration, and often telangiectatic and bleeding easily. So again, telangiectasias, central ulcerations, rolled borders, translucent or pearly in appearance. It's most common in the face and the nose, and you want to do a punch or shave biopsy for this one. For treatment, we can do a Mohs micrographic surgery for facial involvement. So we just do Mohs on the face. So Mohs micrographic surgery can help excise this, and we especially need to treat it not only because it can lead to metastasis, although that is rare, but it's locally destructive and invasive as well. Next one, what is this condition? As you can see, some of this redness around the mouth here. What are the risk factors for this? There's one main one that actually can predispose to this. And how do we treat this? So that's going to be perioral dermatitis. It has a history of corticosteroid use that leads to this. So an inflammatory reaction due to that corticosteroid use. So we must eliminate these corticosteroids. We can use topical tacrolimus, and we could use metronidazole or erythromycin, but tacrolimus is a good one to use, topical tacrolimus for perioral dermatitis due to a history of topical corticosteroid use around this area. Next one, what is this exactly? So what is this? You can see this area right here above the belt. What is that? What are the most common causes of this? What type of reaction is this? And how long does it take to appear? So how long would this actually take to appear after whatever causes it? What are some of the other causes? And what is the treatment? So this is allergic contact dermatitis with nickel. So the belt buckle is nickel in this case, which is the most common cause. And you can see this rubbing against here. So that causes that allergic contact dermatitis. Some other causes of allergic contact dermatitis would be poison ivy as well as poison sumac or poison oak. And it's allergic, so it's occurring over a course of a few days. So allergic is over a few days, whereas irritant would be more right away. So again, type 4 hypersensitivity over a few days, that's T-cell mediated, and that's allergic contact dermatitis with the most common cause, which is nickel, and other causes are poison oak, poison sumac, poison ivy. And how do we differentiate that from an irritant dermatitis? Irritant's going to be occurring right away because it's actually irritating that skin with whatever's on it. So that would be chemicals, detergents, cleansers, etc. And also treatment is avoiding the irritants, and we could also use topical corticosteroids if we need to. So it's important to know the difference between that irritant when it arises and the contact when it arises. Because you might think this thing coming in contact with here, that would lead to an immediate inflammation here, but it could take days as well since it's type 4 hypersensitivity, whereas the irritant, it's irritating it right away, and that's not due to nickel or poison ivy or anything like that. Next one, what is this? What would it be if it doesn't involve the skin folds too? So this one you can see involves the skin folds. What would you think if it doesn't involve the skin folds, and what diagnosis would it be? And what are the risk factors? So this is going to be candidal diaper dermatitis since it does involve the skin folds. So a fungus can grow within those intertriginous areas between the skin folds. However, if it is diaper dermatitis, it's not going to involve the skin folds since it would only irritate the areas where the diaper was actually touching. And typically the diaper, of course, isn't going to touch all the crevices between the skin folds like a candidal infection could spread in there. And the risk factor is feces and longer duration of urine exposure with the diaper on. That can lead to that candidal diaper dermatitis, or if it does not involve the skin folds, it's just regular diaper dermatitis. Next one. So we have poison ivy here. Is a picture of poison ivy and the rash of poison ivy. What would it be if this were in the southwest or southeast? So what would it be if they were in the southeast? And how about in the Rocky Mountains? So if they were in the southeast, what would it be? And if they were in the Rocky Mountains, what would it be more likely to be? That's going to be poison sumac if you're in the southeast, poison sumac, and poison oak if you're near the Rocky Mountains. So you want to be thinking about poison oak if you're in the Rocky Mountains. Okay, what is this condition here? As you can see, these small little vesicles on the hand here. What is this? What is the classic description? There's a typical word that they use for this. And what is the treatment for this condition? So again, what is it? What is the classical description? So this is going to be dyshydrotic eczema. So acute palmoplantar eczema. Acute palmoplantar eczema, dyshydrotic eczema, and it's typically called tapioca-like with small tiny vesicles in the palms and soles of the feet. The treatment for this is corticosteroids. So again, dyshydrotic eczema, you want to be associating tapioca-like. Okay, what is this one? So there's a lot for this one. What is this condition here? What is the risk factor? Like what will the patient have in the vignette potentially? What are the classic 6 P's of this condition? What are the classic 6 P's which can give it away? What is Wickham's striae? And what is Cobner's phenomenon? So Wickham's striae, Cobner's phenomenon, and how do we treat this too? So this is going to be lichen planus. And the thing that you might see in the vignette is that they might also have hepatitis C. So hepatitis C is common for lichen planus. The 6 P's are purple, polygonal, planar, papules, and plaques that are also pruritic, purple. Wickham's striae is fine white lines of the lesions of the oral mucosa. So if you invert their lip and you see those fine white lines, that's Wickham's striae, and that's common in lichen planus. And also Cobner's phenomenon is new lesions at the site of trauma. And what other condition is like this? So new lesions at the site of trauma. What other condition is like this? That would be psoriasis, is similar, also has Cobner's phenomenon. But new lesions, so they get damage in an area, a small laceration or something, and they form new lesions of lichen planus. The treatment is, of course, corticosteroids. Okay, next one. What is this condition? What is the description? And what does it do to? So what does this condition actually do to? So this is lichen simplex chronicus, a scaly, well-demarcated, rough hyperkeratotic plaque with exaggerated skin lines. From repetitive rubbing and scratching of the nose with atopic dermatitis. So they already had eczema, and they're just really damaging that area. So it's going to be lichen simplex chronicus. Lichenified plaques. Corticosteroids, and avoid scratching it as the treatment. Next one. What is the image of this specifically? What is this image specifically showing? What is the classic description of this lesion? In kids, you'll find this where? How about in adults? And what is the pathophysiology? A few more questions about this condition and a similar condition here. What are other strongly associated conditions? What is the treatment? And what symptom is required for the diagnosis? What symptom is required for the diagnosis? So here you can see, in this circular pattern, what would that be called? So this is going to be nummular eczema, the top one, which is a coin-shaped lesion. So that's circular eczema, nummular eczema, coin-shaped lesion. In babies, it's going to be on the extensor surfaces, and in adults and older kids, more on the flexor surfaces. So antecubital fossa, flexor surfaces, that's where you're going to see it in adults and older kids, where, babies are crawling and they're putting their hands and feet and everything. So those are going to be more on the extensor surfaces. The pathophysiology is a defective skin barrier that's susceptible to drying, leading to itching and inflammation. What other patients might have this? People with the atopic triad, such as allergic rhinitis, eczema, and asthma. The treatment is antihistamines for itching and topical corticosteroids. And also they must have itching to have this diagnosis. So it's not eczema if it's not itchy. And avoid triggers of heat and low humidity, and maintain skin hydration with emollients every day. So you want to maintain the hydration of the skin due to that defect in the skin barrier, allowing the moisture to seep out. And again, nummular eczema for this coin-shaped lesion. Okay, what is this? Kind of gives it away with this pattern drawn here. What is this condition? What is the first sign of this condition? What type of pattern is most common? What is the treatment? And where does it not go? So we can see this lesion on the back, obviously, but where does this not travel to? So this is going to be pityriasis rosea. The heralding patch is the first thing we're going to see. So we're going to see one of these being arising first, and that's called the heralding patch, or a herald patch. And this is a solitary salmon-colored macule. So they always say that, solitary salmon-colored macule in a Christmas tree pattern, as you can see. No treatment is likely needed as it's viral and will resolve, and it does not involve areas beyond the trunk and the proximal extremities. So it's not going to spread to the hands for pityriasis rosea, typically mostly on the back, and definitely to the trunk and just proximal extremities. And again, don't forget that solitary salmon-colored macule, which is the herald patch. Okay, next one. What is this condition? This is a classic picture of this condition. As you can see, under the hairline here, silvery, thick plaques and scaling. What is that? What is the pathophysiology of this condition? So pathophysiology of this. What is auspice sign? What is an oil spot, and where is that located? So an oil spot, auspice sign. What predisposes to guttate psoriasis? So that gives it away. This is psoriasis, thick silvery scaling you want to associate with psoriasis. But what predisposes to guttate psoriasis? And what are the 3 C's of treatment for this? 3 C's of treatment. So the 3 C's of treatment is going to be corticosteroids, calcipotriene, and calcineurin inhibitors. So that's just how I remember the treatment for psoriasis. Sometimes they say, oh, the corticosteroids didn't work. What do you want to try next? Well, any of them that have C in it. So calcipotriene, corticosteroids, or calcineurin inhibitors like tacrolimus. And again, this is psoriasis, the thick silvery scaling plaques. It's keratin hyperplasia for the pathophysiology and proliferating cells of the stratum basalis and stratum spinosum of the epidermis due to T cell activation that leads to excess epidermal turnover. So increasing that growth of that cells in those areas in the epidermis. The auspice sign is punctate bleeding with removal of lesion. So if you pick it off, you're going to have bleeding. That's auspice sign. Cobner phenomena, which we already said in lichen planus. Cobner phenomena is from trauma. So if you have some trauma in the area, it creates more psoriasis in that area due to that trauma or laceration. The oil spot is on the nails and it also has nail pitting. So you'll have this discoloration of parts of the nail, and that's called an oil spot. Kind of looks like oil. And also nail pitting. So don't forget the nail involvement in psoriasis. Guttate psoriasis, that's going to be predisposed by strep pharyngitis, so group A strep. So strep pharyngitis can predispose to guttate psoriasis. That's an important one to know. And lastly, again, like I said, 3 C's of treatment for psoriasis. Corticosteroids first, calcipotriene, and calcineurin inhibitors like tacrolimus. Okay, next condition. What is this? What is this condition? As you can see, hypopigmented macules. What is the most common cause? What is the characteristic description of this that they might tell you? What will you see on the best test? So there's a specific finding on the test that you might see with this condition. And how about in a Woods lamp? What if you bring a Woods lamp and you look at it with that? What will you see? And what's the first line treatment for this? So this is tinea versicolor. It's caused by Malassezia fervor, a yeast. It's hypopigmented, well demarcated, round or oval macules with fine scaling that fails to tan. So they're not going to be able to tan in this area because it's covered by that yeast. So it's Malassezia fervor, again, tinea versicolor, hypopigmented, and well demarcated oval macules with fine scaling. They'll say fine scaling. I don't really see any scaling, but fine scaling and fails to tan. KOH, we'll see spaghetti and meatball pattern. So importantly to know, spaghetti and meatball pattern if you do that KOH prep. Spaghetti and meatball pattern. And Woods lamp will show yellow-green fluorescence. So yellow-green fluorescence with Woods lamp. That's when you shine that colored lamp on them and you can see that yellow-green fluorescence. You want to treat it with selenium sulfide, also known as Selsun Blue shampoo. You can use sodium sulfacetamide as well, and zinc parathione. You can also use zinc. So zinc works good for this. You can use selenium sulfide or sodium sulfacetamide. Next one, what is this condition? You can see the baby that has this on its head. What is this condition? What is the classic description of this condition? How do we manage it as well? So this is going to be cradle cap. So seborrheic dermatitis. It'll be described as erythematous plaques with fine yellow or white greasy scales on the scalp. How do we treat? Emollients of the scalp like oil-based emollients like mineral oil prior to shampoo, and you can also remove them with a soft brush. So again, cradle cap, seborrheic dermatitis. And also another question, what population is an important one to know seborrheic dermatitis occurs in? So what older population or what condition would this patient have that could also have seborrheic dermatitis? And also we'll go over hypersensitivity reactions. So what is a type 1 hypersensitivity reaction? What is a type 2, a type 3, and type 4? So we already mentioned some examples of these as we went through, but what are they specifically? And again, seborrheic dermatitis in what population? So this is going to be Parkinson's. So remember, Parkinson's can have seborrheic dermatitis. Also HIV. So type 1 hypersensitivity is IgE mediated, like angioedema, urticaria. So this happens pretty quickly, and that's type 1. So you can just think 1 is the first one. IgE mediated happens very quickly, mast cell mediated, and IgE mediated. Type 2 is a cytotoxic antibody mediated. Type 3 is immune antibody antigen complex like serum sickness or drug mediated vasculitis. So these are going to take a bit longer, type 2 or type 3. And type 4 is a delayed cell mediated like erythema multiforme or like we talked about the nickel for allergic contact dermatitis. This takes a few days to develop. as opposed to like an irritant contact dermatitis. So again, type 4, delayed cell-mediated, like erythema multiforme. Next one, what is this? What is this condition, as you can see? What medication can induce this by what mechanism? So we should know the medication, but by what mechanism does it work? What are the 2 types of this? And what is the treatment for each of these things? So there's 2 different pathways that this could be from, and we need to know the treatment for each of them in order to treat them properly. So of course, angioedema. Angioedema, we can see the swelling of the mucous membrane here. ACE inhibitor and hereditary C1 esterase inhibitor deficiency can be through bradykinin, and it could also be mast cell histamine mediated, would be an allergic reaction. So there's 2 different ways. The 2 different types are either A, mast cell histamine, which would be an allergic reaction, or through bradykinin, which could be hereditary C1 esterase inhibitor deficiency, or it could be ACE inhibitor. So again, 2 different pathways, mast cell or bradykinin. Bradykinin is ACE inhibitor and hereditary, and mast cells, of course, an allergic reaction. And the treatment differs, which is why we need to differentiate them. Mast cell gets epinephrine, corticosteroids, antihistamines, and also bradykinin is different. These are, you can give them these, you probably give them it first and see if it doesn't work, then you assume that it's probably C1 esterase inhibitor deficiency or ACE inhibitor. And these need to get C1 inhibitor concentrate or fresh frozen plasma. And of course, discontinuation of ACE inhibitor. So they get C1 inhibitor concentrate or fresh frozen plasma to replete all the factors that are lost contributing to this. Okay, what is this condition here? What is this condition? What type of hypersensitivity is it? We just mentioned it. And what is the treatment for this condition? So what is this condition? What is the type of hypersensitivity? And what is the treatment? This is going to be urticaria. It will be described as circumscribed hives or wheals that are blanchable, raised erythematous areas on skin or mucous membranes. It's a type 1 IgE arising, so it immediately arises as opposed to that type 4, which we talked about, which is delayed. So this is immediate type 1 IgE hypersensitivity reaction. Again, urticaria, and this is a wheal here. How we can treat it is antihistamines, H1 blockers like CFL, cetirizine, fexofenadine, and loratadine. Those are your H1 blockers, and corticosteroids if severe. So that is how we treat this wheal as well. Next one, what is this? Where is the most common location for this ulcer? So what is this? Where is the most common location? And what is the initial management for this? So you can see that this is venous stasis ulceration and dermatitis. So venous stasis ulceration and dermatitis, more common in the medial malleolus. Remember, peripheral arterial disease is more common in the lateral malleolus. So medial malleolus around the medial side of the ankle, lower limb here. It's worse with dependency and better when we elevate it, of course, because it's underlying venous insufficiency. So we want to drain the leg. It's hyperpigmented and brownish and dark purple due to the hemosiderin deposition in the skin. It's a result of venous insufficiency, like we said. You want to do compression stockings for management, exercise, elevation, and also treat the underlying cause. Okay, what is this condition here? What is this? What is the pathophysiology? What is the treatment? So this is going to be vitiligo. One of the proposed mechanisms is autoimmune destruction of melanocytes leading to skin depigmentation. But again, overall, poorly understood. You can try topical corticosteroids. You can also try systemic phototherapy as well. And there's also some treatments to speed it up if you just want to eradicate all the melanocytes so that your new skin tone is the depigmented skin tone. Next one. So what is this condition? It might be hard to know if you don't know the fact that what if this person is pregnant, then what would this condition be? And what is the treatment for this? So let's say this person is pregnant. What is this condition on the face? So that's going to be the mask of pregnancy, and it's melasma or cloasma, and it's hypermelanosis of sun-exposed areas of the skin due to pregnancy or OCPs from increased estrogen. So increased estrogen leads to this. It's a mask-like hypermelanotic symmetric macules. You want to do sun protection. You can also do triple treatment with fluocinolone, hydroquinone, and tretinoin. So those are some of the treatments, and it's typically in patients that are pregnant, the mask of pregnancy. Okay, now we're going to go into a little bit more complex topic, name the burn type. So we're going to do burn types and a few other things to do with burns. So I'm going to describe the burn type, and you'll have to know what type of burn it is. So there's 4 different types. So first one is a patient that has blistering. They have a non-painful burn unless when you apply deep pressure. So it's non-painful until you apply deep pressure. There is absent cap refill, and the epidermis and reticular layers of the dermis are affected. What is this? So that's question 1. Question 2, it's a burn of the epidermis. There's erythema, pain, tenderness to palpation, and dry appearing without any blistering. So again, epidermis, painful, tender to palpation, dry appearance without blistering. Question 3, there's a waxy, white, leathery appearance. There's absent capillary refill, and also lack of blistering and lack of sensation. Lack of blistering and lack of sensation. Number 4 here, blistering of the epidermis and dermis being affected. There are erythematous and pink moist skin, very tender to the touch with intact capillary refill. What is that? Okay, so now the answers. Question 1 is going to be a 2nd degree deep partial thickness. So it's deep partial or superficial partial thickness. So the first one was 2nd degree deep partial thickness burn. How do we know this? Is that there's pain upon deep pressure and there's still blistering. So if there was no blistering, then we might think it's full thickness. But if there's pain without deep pressure, then we might think it's 2nd degree superficial partial thickness. So what clues us into 2nd degree deep partial thickness is that there is pain, but only upon deep pressure, and it still remains to be blistering. Question 2 is 1st degree, of course. Question 3 is a 3rd degree full thickness because there's no blistering. It's already past that point where it could blister, and there's also no sensation. We've already burned through all the nerves, even with deep pressure. So that's a 3rd degree full thickness. This last one, number 4, 2nd degree superficial partial thickness. Again, 2nd degree superficial partial thickness. Note that there is pain and intact cap refill with blistering. So again, 2nd degree does have that blistering, but the difference is, again, deep pressure is needed for deep partial, whereas superficial partial, you don't need deep pressure to call it that. It's just regular, there's pain. Okay, next question. Name the amount % burnt. So it often gives you a question and it tells you patient was burnt here and here, what percentage of their total body surface area was burnt. And then you have to pick the correct percentage. They might give you like 27, 36, 48, 55 or something like that. So we'll go through a couple practice questions here in regards to that. And the age does matter here. A 39-year-old has their whole left arm burnt, front and back, and their whole leg on both sides. What is that percentage? So what is this person burnt? A 2-year-old has their whole right leg burnt and their whole back burnt. What percentage is that? So again, whole right leg and their whole back burnt. What percentage is that in a 2-year-old? And last one, question 3. A 55-year-old has the front of the right leg burnt and the back of his left arm. What is the percent? So again, the front of the right leg and the back of his left arm. What is the percent? Okay, so for question 1, it's going to be 27%. 27% for question 1, because the arm is 9% and the leg is 18%, and they did the both. They were the whole of each. So the arm 9, leg 18, 27% total. Question 2 is 32%, and this was in a 2-year-old, so we have to remember that the leg is actually 14% in a 2-year-old or any kid. So the leg is 14% here, plus 18% for the back, so that equals 32%. Question 3, the answer is 13.5%. Remember, half the arm is 4.5. We said just half of the arm is affected, and we said just half of the leg is affected, and that's 9%. So again, 13.5% for our 55-year-old here. And here's the chart that's a reference for that. So again, 14% for the legs of the infant, which is different, and the infant also has more percentage for the head there at 18%. What is the most commonly used burn dressing? So what is the most commonly used burn dressing? We just finished up the rule of 9s here. Most commonly used burn dressing, rule of 9s is not used for what degree of burns? So what degree of burns is the rule of nines not used for? What burns require dressings and topical antibiotics? And what is the Parkland formula for fluid resuscitation? What is the Parkland formula for fluid resuscitation? An important question to answer. So SSD, silver sulfadiazine, is the most common, and also silver nitrate. It has antimicrobial and anti-inflammatory properties. Rule of nines we don't use in first-degree burns. Partial and full thickness burns, we do topical antibiotics and dressings. So again, partial and full thickness burns. The Parkland formula, important to know, is 4 milliliters per kilogram per percent burn. So those three factors you need to get. 4 milliliters per kilogram of weight of the patient per percent burnt. So whatever percent you've calculated that they're burnt, that's not first degree, is how you want to calculate that. Also remember they need maintenance fluids too. So you might be using your LR for those resuscitation fluids, but remember you also need to calculate maintenance fluids as well. And for those fluids that you're talking about here for fluid resuscitation, you want to give half, 50% in the first 8 hours, and the second half of those fluids in the next 16 hours. So you front them with a little bit extra fluids, half of it in the first 8 hours, and then the second 16 hours, you want to give the rest. You want to give the second half. And that's lactated ringers, which is the best fluid. So next one, we're going to talk about pressure ulcers. What stage is the pressure ulcer? I'll have a picture after this to give a visual representation of it, but here are a few questions, and you should know based on the description of it, as that's potentially what they might only give you for information. So question 1 is a full thickness of the skin may extend into the subcuticular layer, the hypodermis, and the adipose. So it's a full thickness pressure ulcer of the skin that extends into the subcutaneous layer, the hypodermis, and the adipose tissue. What is that? How about question 2, epidermal damage extending into the dermis, resembling a blister or an abrasion? How about question 3, extends beyond the fascia into the muscle, tendon, or bone? What's that? And question 4, non-blanchable redness that does not dissipate after the pressure is removed. What is that? Again, non-blanchable redness, no dissipation after the pressure is removed. What is that? In question 5, sloth and black eschar that covers the wound and obscures it. What stage is that? So technically five different types of stages here. So the answers are, question 1 is stage 3. So stage 3 is full thickness into the subcutaneous, hypodermis, and adipose. So stage 3 goes all the way into the adipose. Question 2 is stage 2, extends into the dermis, resembles a blister or abrasion. So it extends into the dermis, but not yet the subcuticular layer or the hypodermis and adipose. So this is stage 2, just into the dermis. So you think about it, layers of the skin. So of course then, question 4 would be stage 1 because it's non-blanchable and it's just the epidermis. Stage 2 is into the dermis, and stage 3 is into the subcutaneous and adipose. And like we said, number 3 is a stage 4, so that extends beyond the fascia into the muscle, bone, and tendon. And of course, stage 5 is unstageable because there's black eschar and that obscures it. And here's a visual representation of those. Here, stage 1, 2, 3, and 4, and also the unstageable with the black eschar over top. So next one, a pretty horrendous condition here. What is this? What is the pathophysiology of this? How old will the patients be, which helps us determine its difference from its counterpart? And also, what else helps us determine the difference between that and something else? So this is going to be pemphigus vulgaris. Pemphigus vulgaris. This is a blister disorder of type 2 hypersensitivity that has autoantibodies against the desmogliin, leading to separation of the dermis, typically in 30 to 40-year-olds. So how I remember this is vulgar is bad. So vulgar is bad, and it's an early age, so it's worse. So typically, like severe diseases that occur to younger people, I always think of as worse as opposed to older people. So it's vulgar is bad. It occurs in earlier 30 to 40-year-olds. And at early stages, it's painful flaccid bullae that rupture easily. It'll have a positive Nikolsky sign. So again, as you can see, ruptured easily, positive Nikolsky sign in pemphigus vulgaris. And then if that's pemphigus vulgaris, what is this condition? And how do we differ it from pemphigus vulgaris? As you can see here. And this is, of course, bullous pemphigoid. And this occurs most often in the elderly, so different from pemphigus vulgaris, which is more 30 to 40-year-olds. It's not as bad as pemphigus vulgaris. And it's subepidermal blistering, IgG autoantibodies against the hemidesmosomes, and this results in tense, large bulla that do not rupture easily, a negative Nikolsky sign. So again, pemphigus vulgaris, positive Nikolsky sign, bullous pemphigoid, negative Nikolsky sign, pemphigus vulgaris, rupturing easily, bullous pemphigoid, tense, large bulla that do not rupture easily. And again, bullous pemphigoid, mostly in the elderly, as opposed to vulgaris, which is younger. Okay, next one. What is this condition here? This is an easy one that we should know. What is this condition? What is a common coinciding condition to this? And how is this typically described? There's a couple common descriptive words used for this one. This is acanthosis nigricans. Acanthosis nigricans. It's typical in patients that are obese, also diabetes and Cushing syndrome. It's poorly defined, hyperpigmented, velvety thickened plaques. Velvety thickened plaques, importantly. Skin folds is the most common area, especially the neck as well as the axilla. Okay, next one. What is this condition here? So what is this condition? What are some risk factors for this condition? What are the manifestations? And what is the first-line treatment for this condition in mild? So this is going to be hidradenitis suppurativa. The axilla is the most common area. It's due to a chronic follicular hair follicle obstruction. The risk factors are obesity, females, smoking, and acne history. It's deep-seated inflammatory nodules and abscesses, draining tracts, fibrotic scars as well. The first-line treatment is clindamycin, although you may need surgical drainage as well if that doesn't help. Clindamycin. Okay, what is this condition here? This kind of bulge. What are some of the characteristics of this? Like, how might they describe this? So this is going to be a lipoma. Soft, painless subcutaneous nodule. It's easily mobile, and it's a clinical diagnosis. So if you're pressing on this, it'll be easily mobile and soft. Next one. What is this condition here? What are some characteristics of this condition? What must we ensure to decrease the chance of recurrence? So how do we make sure this doesn't recur in the same location again? So this is an epidermal inclusion cyst or a pilar sebaceous cyst. So epidermal inclusion cyst, pilar sebaceous cyst, it's freely mobile, compressible, cyst or nodule with clinically visible central punctum. That's right here. That's the dark comedome. It may lead to a foul yellow-white discharge that is cheese-like in nature. And if we want to decrease the chance of recurrence, we need to excise the whole cyst wall. So we need to take out the whole cyst wall. Okay, what is this condition and what is an associated condition with this? So this is going to be pyoderma gangrenosum. So this is pyoderma gangrenosum, most commonly associated with inflammatory bowel disease like Crohn's or ulcerative colitis. They'll have painful necrotic ulcers with irregular purple or violet raised or undermined borders and a purulent base. Corticosteroids is the treatment. So again, inflammatory bowel disease, Crohn's or ulcerative colitis for pyoderma gangrenosum. A pretty gruesome disease here. What is this and how do we treat it? So this is going to be a keloid. Injection of corticosteroid is the treatment. However, they are difficult to treat. They're more common in darker skinned individuals. And also it's a buildup of type 1 and type 3 collagen as well. What is dermatitis herpetiformis associated with? So if we hear dermatitis herpetiformis, what do we think that's associated with? What is the first line treatment for this condition? What Ig complex, immunoglobulin complex deposition occurs in this condition? So again, dermatitis herpetiformis. So that's going to be celiac disease. The first line treatment for dermatitis herpetiformis specifically is dapsone and IgA. So remember IgA, the immunoglobulin that coats the GI tract as well as mucous membranes. And also you can know that IgA is involved in celiac disease as well. IgA tissue transglutaminase is how we can screen as well. Getting closer to the end here, what is this condition? And what is the classic description of this condition here? So this is going to be a pyogenic granuloma. It's not pyogenic, nor is it a granuloma, but this is what it's called. Pyogenic granuloma. It's a solitary, glistening, friable red raspberry-like nodule that may bleed or ulcerate. It also has rapid growth. So again, raspberry-like nodule, pyoderma, or pyogenic granuloma. What is this one? As you can see, some red nodules on the shins here. And what are some common etiologies of this condition? So there's a few important conditions to know that are associated with this one here. So infections are the most common cause, and especially strep, coccidiomycosis, sarcoidosis, and estrogen exposure and IBD. So this is erythema nodosum. There's nodes here, and they're typically on the shin. And you can remember, especially sarcoidosis. It's especially common in sarcoidosis, but infections are the most common predisposer to that. And also inflammatory bowel disease. And lastly, what is this one here? Little red dots here. That's going to be cherry angioma. Cherry angioma for this condition here. And that will finish up all the dermatology questions for this section.